Thank you so much for that introduction. My name is Dr. Shikha Jain, and I am an oncologist at the University of Illinois in Chicago. And today I'm going to be talking to you a little bit about women in medicine. So today we'll start with the history of gender in healthcare. We'll move on to talk about implicit bias and some of the things that are holding women back. We'll move on to talk about COVID-19 because in 2020, no talk is complete without talking about how COVID-19 is impacting us. And then we'll end with some solutions. So women made up over 50% of new medical school enrollees in 2017. However, despite the fact we are seeing these increases in the number of women in medical school, we aren't seeing these types of increases in leadership. For example, the AAMC published a report, The State of Women in Academic Medicine, and they showed that only 21% of full professors were women, and 16% of deans and 15% of department chairs are women. This was from a couple years ago. Those numbers are pretty close to what they are now. Women still make up less than 20% of deans and chairs of departments in this country. And that is not representative of the number of women who are earning medical degrees. So we'll talk a little bit today about why that's a problem and why that's happening. So I get asked often, why is it so important to fix these gender imbalances? And there's a lot of reasons, but some that I think are really important to point out. Number one, we want to make sure that our medical students are being taught and trained to their fullest potential. So if we have all these amazing women who are entering medical school, who are brilliant and ambitious, why aren't we seeing those women in leadership positions? And if that's an issue, we need to address it. Future physicians training in institutions that reflect diverse makeup of the population. So our country is very heterogeneous, and there have been numerous studies showing that the women who treat patients have improved outcomes. There are studies that show women have a decreased readmission rate of patients who are admitted to the hospital. And really, we have seen in numerous studies that when patients are treated by physicians who look like them, they tend to feel that their quality of care is better delivered. So we need to make sure that the population we're treating is represented by the physicians and the leaders who are treating that population. And it's also extremely important that women's health issues continue to be researched and taught, which we know is directly related to women starting these different types of initiatives. For example, back in the 1970s, which was not very long ago, the FDA had a policy that prohibited any woman of childbearing age from participating in early stage drug trials. Women were also excluded from many observational trials. And it wasn't until 1993 that Congress passed a law that women needed to be included in NIH-funded research. So what does that mean? It means a lot of the medications, the treatments, the diagnoses that we rely on right now are based on 50% of the population. And men and women obviously are physiologically different. So the fact that all of these trials were done without women being a part of the trials means that women are likely being improperly dosed with medications. Women often are being underdiagnosed with medical problems. For example, we know that men and women present differently when they present with cardiac problems or heart attacks. So it's extremely important that we continue to teach women's health. And there have been numerous studies that have also shown that many times women are the ones who are driving these women's health studies. So one thing that Dr. Julie Silver, a leader and pioneer in this field, published a couple of years ago is the Be Ethical campaign. And she put it out as a call to healthcare leaders. And she stated that ending gender workforce disparity is an ethical imperative. Her quote that is quoted often is, "With its unusually large proportion of highly educated and qualified women, medicine should be leading the way in gender equity. Leaders who have it within their power to address barriers to the advancement of women and all underrepresented people should behave ethically and resolve to act expeditiously and with steadfastness." So what Dr. Silver did in her campaign is she laid out some common reasons that people identify why they feel gender inequity still exists. And then she came up with some solutions. So first, she pointed out some critical thinking errors, and I think it's really important to address these because there are many people who think gender inequities do not still exist in healthcare. So the first critical thinking error she points out is perpetuating myths. For example, that there aren't enough qualified women or women aren't as skilled or dedicated as men, which is false. We know that women enter medical school, men enter medical school, and they are ambitious, they work hard, and there is a lot of data showing that there are qualified women who simply get discouraged or find that the barriers to achieve what they want to achieve are simply too great and impossible to traverse. Holding the affected group responsible for deficiencies in the system. So, for example, people would say women's childcare responsibilities interfere with their career advancement. Women need to find better mentors. Women need to be in charge of fixing these disparities. The challenge then occurs, women are responsible for fixing the disparities. Women aren't in the leadership positions to make these disparities go away. And women are punished for needing things like maternity leave. So holding the affected group responsible is not a way to fix these problems. Preserving willful ignorance about the problem. So for example, leaders saying they don't know the evidence on workforce disparities, or they continue to perpetuate some of these critical thinking errors. These are all major problems when it comes to trying to close the gender gap. Women work part-time or women aren't as ambitious. There are several studies that have shown that inequities exist when accounting for higher number of women physicians working part-time. So these studies that are coming out show very clearly that even if we account for the fact that there are women working part-time or women taking time off for during their childbearing years, they still show that these inequities exist. Not enough women in the pipeline. Women don't want to be leaders. Women don't have leadership skills. I don't have to tell you that these are critical thinking errors. They are. And a big contributing factor is that there's a lack of women in leadership positions. There's a continued and persistent gender pay gap. There are stereotypes that exist, implicit bias, and then of course, self-confidence issues or imposter syndrome or imposter phenomenon. This year, Dr. Silver has come out with a new initiative called Her Time Is Now, which is a call to healthcare leaders. And she really wants to focus on the fact that now is the time to focus on ending these workforce gender disparities. She states the future has always been considered an ideal time to address gender equity. The strategy has not worked well for half of the world's population, so her time is now. So let's talk a little bit about some of the things that contribute to these persistent gender inequities. First of all, implicit and unconscious bias. So this is not a new phenomenon that implicit bias impacts gender disparities. Back in the post-Civil War time, there was a women's medical movement, and it was the first generation of women who became physicians who were able to advocate that women were actually inherently healthy. Because up until that point, women were seen as sickly and frail, and they weren't allowed to do a lot of things because there was this persistent stereotype that women were not capable because they were less strong and they were more frail than their male counterparts. So again, this goes to show women physicians, when they began advocating for their female patients and for themselves, that's when a change started to happen. And this implicit bias has been around for years. So what is implicit bias? So implicit bias are ways that people are individual or singled out. It's ways that people can be overlooked or ignored based on things that are unchangeable. So their race, their gender. We all use unconscious bias to filter information. We use it to organize the world and kind of figure out how to navigate our social groups. And we use it to process and recall information. But it's really important that we uncover our own implicit biases and our own blind spots so that we can ensure these types of biases don't impact the way we interact with others and impact our behavior. There's studies on hiring that have shown that men and women both show a stronger preference for male candidates, even when all the application material is identical. When women enact a more masculine style of leadership, they see that they are found to be scored lower as leaders, and that's by both men and women. So women can't be leading as men, but they also can't be leading as women. So this leaky pipeline occurs because this deck is stacked against them from the beginning. And then for women with intersectionality, this is an even bigger problem. I don't know if you remember a couple years ago and multiple times since then, there have been female physicians who have been on airplanes who have tried to help a passenger that's fallen down, and they've been questioned quite rigorously about whether they were an actual physician. I'm going to show you some studies that go a little bit more into detail about these implicit biases. So we should use different words to describe male and female leaders. This is a study that was done looking at managers who were describing men and women in performance reviews. And as you can see on the left-hand side, for men, they were more likely to describe them as task-oriented, more able to strategize. They were analytical, competent, dependable. The women, their strengths were described as compassionate, enthusiastic, energetic. The problem is people who are analytical are seen as people who are able to strategize and lead. People who are seen as compassionate, while that is a very important leadership skill to have, they're often seen to be more relationship oriented. They contribute to a positive work environment. But that type of skill is often scored lower when trying to decide who has more leadership potential. I think this study is especially profound. This was a study looking at men and women entrepreneurs. So the male entrepreneurs are described as young and promising, so a positive. Women were described as young but inexperienced. So the exact same quality the male had, but it was a positive for the man and a negative for the woman. Men were described as experienced and knowledgeable. Women were described as experienced but worried. Again, a positive for their male colleagues and a negative for the women. Very competent innovator and already has money to play with, versus good looking and careless with money. So if you're a man and you have money to play with. If you're a woman and you have money, you're careless with it. Cautious, sensible, and level-headed versus too cautious and does not dare. I think this is a very, very common thing that we see. And again, it goes to implicit bias. Many times people don't even realize that these are the ways they're describing their male and female colleagues. And it has nothing to do with their capabilities, but it has to do with our own implicit and unconscious biases. Let's talk about some more data. This resume study, I think, is pretty impressive in showing the differences in how we rank men and women. So this was a study that came out of Yale. It was randomized, double-blind, and they asked 127 scientists to review job applications at 6 major academic institutions for a position of a lab technician. So it's a scientific lab. They randomly assigned the name either John or Jennifer to the top of the resume for an identical position. The male candidate scored higher on numerous criteria. For example, John scored a 4 for competence and Jennifer had a 3.3. Keep in mind, the entire CV, the entire resume was exactly the same. The only difference was the name at the top. Both men and women were more likely to hire the man. They ranked him higher not only in competency, but they were also willing to pay him 13% more than the woman. And they were also more willing to provide mentoring to the male candidate versus the female candidate. And again, I want to remind you, this was 2 identical CVs. This bias persisted after controlling for the professor's age, sex, teaching field, and tenure status. So you can see here, the competence, the hireability, and the mentoring were all higher for the man, and the salary was significantly higher for the man. Now, again, the only difference on these 2 resumes was the fact that at the top, one said John and one said Jennifer. Speaker introductions. So this study we published a couple years ago looking at the way speakers were introduced at the American Society for Clinical Oncology. We found that women speakers were less likely than men to receive a formal address, and women were more likely to be introduced by their first name only, 17% versus 3%. We found that Black speakers of both genders were less likely to receive a professional address as well. So why does this matter? Well, these professional titles, when people are introduced, it really affects the perceived expertise and authority of the person who's speaking. It reinforces this perception that women are of lower status, and it can negatively impact people's career trajectories as well as their career satisfaction when they aren't seen as an expert. These unequal naming practices have also been shown to increase isolation, feelings of marginalization, and uncomfortable feelings in professional life. This leads to a leaky pipeline, which means it's difficult to retain women in part because they aren't equally compensated, they don't feel equally valued, These gender disparities, women know that these disparities will result in limiting earning potential and career advancement. And there's a real lack in mentorship and sponsorship and coaching for women. And so this all leads to this concept of the leaky pipeline. You can see in this graph on the upper left-hand side, this leaky pipeline is pretty prevalent and pretty obvious when you look at academic promotion. If you look at the initial matriculants to medical school, and then you look all the way up to the dean level, for the women, it's a pretty consistent drop in the number of individuals who are being promoted and who are advancing into these leadership positions. And for men, it's a pretty consistent increase. If you look at NIH grants, so women are less likely to receive grants, and the grants that they receive are smaller. For example, the study that came out of the NIH looking at the funding gap, showing from 2002 to 2012, there was not a very big difference in the amount of grants that were, the size of the grant that was going out to women and the number of grants that were going out to women. Awards. So Dr. Silver has published, and several other colleagues have published on the fact that awards are lacking for women. For example, in this study looking at physical medicine and rehabilitation, they found that looking at men versus women receiving awards, 42 versus 222, looking from 1968 to 2015. And then looking at 2006 to 2015, approximately 42% of academic physicians in this specialty were women, but for 4 years in a row, none received awards. So Dr. Silver states, for any award in medicine, there are more than 0 women who deserve it. Let's talk a little bit about work-home life. So I shared with you how these implicit biases can impact women's career trajectories, how they can impact women's professional development, and how they can impact women's feeling of being valued at work, and why that sometimes leads to this pretty significant leaky pipeline and a lack of resources and awards and funding for women. Let's talk about how work-home life affects that. So this study came out a couple of years ago, and it looked at levels of emotional exhaustion in men and women. And looking at this study, I laugh because I find it amusing every time I describe it. So for men and women who were single or divorced, they had about equal levels of emotional exhaustion. When women entered into a committed relationship, their level of emotional exhaustion went up, and for men it went down. And when women became married, their level of emotional exhaustion went up even higher. And for men, it went up slightly. Now let's talk about having children. Again, at the beginning, when there were no children, men and women were relatively close in their levels of emotional exhaustion. However, after having children, for women, that level went up, and for men, that went down. This is pretty impressive data, and it's statistically significant, as you can see, with a p-value of 0.02. I think it's important to point this out because while men have been stepping up at home, while partners have been stepping up at home, and we are seeing more sharing of the burden, there is still a long way to go. And we need to make sure that we consider this as we are supporting, sponsoring, and mentoring our women colleagues. The wage gap. So we know there's a persistent pay gap in medicine. There was a study that found that women doctors, female doctors at public medical schools tended to make less than their male colleagues. And you can see that goes from neurology all the way to orthopedic surgery. And these are pretty large differences in money. I will tell you a little bit more. So this study that came out of Medscape, among specialists, who earns more, men or women? You can see for women, it's $286,000, for men, $375,000. For primary care physicians, who earns more, men or women? $212,000 versus $264,000. For specialists, their average base salary and their incentive bonus. You can see again, men and women, there's a stark difference. And same thing when you're looking at physicians' income by age range and gender. Not only are we seeing a persistent gap, we're seeing a persistent gap throughout the times of the career. So from under 34 all the way up to 55 or older, there is a persistent pay gap, and that is a problem. So this came out of CNN the other day. The gender pay gap for women is big, and it's getting worse. Women doctors earn an average of 27.7% less than their male counterparts in 2017. And that's an average of $105,000 less per year. Calculate how much that is over a career, and that's a lot of money. paper coming out in Forbes looking at this study that recently came out, looking at how the practice composition and sex differences in physician incomes actually affects the pay gap. So they found that women working in a medical practice that was primarily men could cost women physicians $90,000 or more. This was a national survey of physician salaries in the US, looking at over 18,000 physicians. And they found that non-surgical private practices with men and women physicians being equal, men earned 12% more than women. In a practice that had 90% male staff, the gap jumps to 20%. And again, female physicians in those male-dominated practices earn as much as $90,000 less a year. The sad thing, even sadder than that, is a lot of this research that I'm showing you, a lot of the work that is being done to identify the implicit bias, to identify the pay gaps, to identify the lack of awards and the lack of funding, is all done by women. And it's done by women in what we have called the third shift. So the challenge is the third shift is that time that is spent, that women spend doing this type of equity research. It's often unfunded, it's often unrecognized, it's often unappreciated, but it's the only way this data is getting out there. And so we have had many discussions nationally, and many leaders are discussing the fact that this equity work, all of the data that I've shown you and so much more, should really be funded. And it should be appreciated, and it should be seen as contributing to the field, when unfortunately right now it is allocated to this third shift where it's not appreciated and it's not funded. And it's done really in the free time of many women physicians. So no talk in 2020 is complete without talking about how COVID-19 has impacted all of us. So COVID-19 has been a national, it's impacted everyone. It's impacted everyone across the globe. The concern, one of the big concerns emerging from this pandemic, is how it's going to impact the inequities that have already existed in healthcare. The challenge is, we know that public health crises like this often set back gender equity efforts decades. There have been many studies that have come out and many perspective pieces that have come out talking about how COVID-19 is currently adversely impacting women physicians, how it's going to impact the pay gap in medicine, why it's a disaster for this type of gender equity work, and how this pandemic really has impacted our women in medicine. One great example, this paper that came out of JAMA, looking at the number of manuscript submissions by women. And they found that manuscripts with a male or female first, last, or corresponding author that were submitted. So this is one journal. If you look at the percentage for women, it has gone down or stayed close to the same. So for senior author, it's gone from 27% to 21%. And for a corresponding author, from 29% to 22%. For first author, 33% to 29%, while for men, it has gone up in all three of those categories. So this is just one study, but there have been many other journals who have been expressing that they have seen less papers coming through from women physicians and from women contributors. Now, this is only one example of how COVID-19 is going to impact our female colleagues. The question is, what can we do to prevent this from happening? How can we prevent COVID-19 from exacerbating these gender inequalities? How can we, as one paper stated, how can we bring a gender lens to our COVID-19 response? And there's a lot of solutions, and I don't have time today to talk about all of them, but I'm going to share with you one that's specific for those who are in the academic realm and those who are up, or those who are in the clinical space and who are trying to go up for a leadership position, or who are trying to advance their professional careers. So we created a CV matrix to improve gender equity by accounting for this COVID time. And it's something that you can access from the Women in Medicine Summit website. And the purpose of this matrix for these for women and men during this COVID time is to identify how your life and how your professional life specifically has been disrupted during this time. For example, if you have research studies that have been halted due to funding or due to collaborators not being available, or you just not having the time. Education, service things that you have done. For example, there are different ways that people have been sent to different COVID units, or who have been reallocated. Their workload has been reallocated in order to deal with the surges happening in the hospital. There are a lot of physicians who have been coming out doing a lot of advocacy work and doing a lot of education through op-ed writing, through communicating with their local news media, through just speaking out, from creating petitions and campaigns. A lot of social media activity that's been happening, that's been being utilized to bring information on the pandemic and on other medical issues to the public. There are a lot of ways to account for this COVID time and to explain what you have been doing during this last 8 to 9 months, especially if you are somebody who is on a promotion track, who it was expected that you were going to have this number of papers published in this amount of time. I think it's really important to remember that we need to account for this time, and this matrix is something that can be utilized to help people almost justify what they've been doing in the last 9 months, and explain and show what has been going on, and explain why they haven't been able to produce what needed to be produced in that amount of time, because we are living through an extraordinary time in our history. So why does any of this matter? Well, we know that this lack of opportunities and mentorship leads to a long-term impact on the advancement of women, especially in academia. We know that these unconscious biases and implicit biases lead to women physicians feeling marginalized. We see this represented in an increase in burnout and decreased job satisfaction. The Office of Research on Women's Health at the NIH has shown an inextricable link between the advancement of women's health and the advancement of women in medicine. So this isn't just important for our women physicians, it is extremely important for the patients that we treat. Why do we think leaders should pay attention to this? Well, it's been found that organizations with pay equity have been proven to have improved overall performance. They have greater trust in leadership. They have improved job satisfaction. They have improved productivity. More innovation and creativity comes out of these hospitals that are led thinking of gender equity and how to make sure that they are working and leading in an equitable environment. Better retention and more awards. So what can you do? So Dr. Silver gives some examples in the Be Ethical campaign of things that can be done. So first of all, let's talk about the facts. Documented disparities we know have profoundly hindered the career of women in medicine, period. That is a fact. Workforce discrimination jeopardizes patient care and scientific discovery, period. That is a fact. Disparities tend to be greatest for women with intersectionality, for example, women of color. That is a fact. Workforce disparities contribute to physician burnout, and physician burnout is more prevalent in women. That is a fact. Historical explanations such as a lack of highly qualified women physicians cannot account for the disparities that persist today. That is a fact. And finally, tokenism has been cited as being harmful, particularly to the token individual. The point being, we need to elevate our qualified women colleagues. There are many, many women out there who are equally, if not more so qualified. They just aren't being looked at. So it is incredibly important that the women who are advanced into these leadership positions are not just advanced because there needed to be a woman on the board. It needs to be because they are equally or more qualified than the other candidates. So what can leaders do? They can make workforce gender equity an ethical imperative. They can prioritize and properly fund the initiatives to close these gender equity pay gaps so that third shift is properly funded. They can avoid critical thinking errors, use a systemic process and systemic metrics to evaluate disparities, and implement strategic interventions. What can you do? So you can be an upstander, not a bystander. First, realize that these issues exist, critically analyze the decisions you make, and then make a conscious effort to practice things that will limit and decrease your unconscious bias and how you interact with others. My favorite example is to be an upstander, not a bystander. So if you're in a meeting when someone speaks over someone else, or if you're in a meeting where one person gives an idea and someone else then restates the idea, bring it back to the first person and say, hey, Jennifer, I loved when you initially mentioned that idea a few minutes ago. Would you be able to restate it? And thank you so much, Tom, for explaining Jennifer's idea in a different way. Be introspective, promote women, quote women, invite women, nominate women, advocate for pay equity, If you're a leader, set up annual reviews where you establish goals for promotion and make sure you have standardized questions and objective ways of interpreting how people are functioning. And finally, I encourage you all to register for the Women in Medicine Summit. It is, if you miss registration for this year, we will be coming to you every year, and we have excellent content that comes out throughout the year. Come to our website, sign up for our newsletter. We work tirelessly to try to come up with solutions for you at an individual level and for leaders at institutional levels to close the gender gap in healthcare. So I strongly encourage you to check out our website. And if you have the opportunity to come to one of our conferences, wonderful. If you don't, that's fine. Just look us up. We have compendiums. We have a lot of great resources and data published by phenomenal faculty from across the country. So I encourage you to check us out. And with that, I want to thank you for your time, and I appreciate the opportunity to speak on this extremely important topic.